Dear audience, my name is Regina Molnár, and I would like to introduce you to our projects in the context of new insights into the development of abnormal glucose tolerance in cystic fibrosis. I'm a PhD student and part-time work at Translational Pediatric Institute, and my supervisors are Andrea Parnitsky and Klementina Ocskai. My vision is that one day CF-related diabetes will not worsen the life quality of CF patients, and as a first step, my mission is to provide new screening strategy for earlier diagnosis of CF-related abnormal glucose tolerance. Here you can see the list of our two ongoing projects, which are strongly related to each other and investigate the role of pancreatic islet autoantibodies in CF. Why did we choose this topic? Because as we've heard before, CF-related abnormal glucose tolerance is the most common extrapulmonary complication of CF. And besides worsening the life quality of the patients, it significantly increases the overall mortality rate. Moreover, an abnormal glucose tolerance can begin in early childhood, and from ferret studies, it's described that an endocrine pancreatic dysfunction can be found even at birth. This endocrine dysfunction is mainly due to physical damage to the pancreas with bystander beta cell death, and with destruction to the beta cells, originally intracellular autoantigens are released, and through other mechanisms, they activate the immune system, which drives the development of an autoimmune setting. In type 1 diabetes, the role of islet autoantibodies is well established. According to the TEDdy study, 34% of children with islet autoimmunity develop diabetes in time. However, screening for such islet autoantibodies is with limited recommendation in the CF population and with only a theoretical level of recommendation, therefore not commonly used. Because of this, data is missing about islet autoantibodies in CF, so with our first project, our aim was to determine if they could contribute to the development of abnormal glucose tolerance. So first, we are investigating the prevalence of islet antibodies in CF through a systematic review and meta-analysis. Here you can see our clinical question, and we investigated CF patients with the measurement of islet antibodies, and their primary outcomes included the age of onset of an abnormal glucose tolerance and the presence of the islet autoantibodies, including any and multiple positivity as well. Our hypothesis was that islet antibodies are present in a significant proportion of CF patients with abnormal glucose tolerance. We conducted a systematic search in 4 databases and a forward-backward citation chasing, and altogether included 20 studies in our analysis. We calculated prevalences and odds ratios with 95% confidence interval, and here you can see a list of our analyzed outcomes. Unfortunately, some of our primary and most of our secondary outcomes were only eligible for a systematic review. So let's move on to our results, and here's our first forest plot showing us the pooled prevalence of islet antibody positivity in patients with cystic fibrosis. The most frequently screened antibody in our study was GOD, screened in 12 out of 20 studies, and the least frequently screened was zinc transporter 8, screened in only 2 studies. For risk of bias assessment, which you can see on the right side of the slide, we used the GBI checklist, and the red columns show the percentage of the studies with low quality and high risk of bias, and the yellow ones, the moderate ones. So in these analyses, we had studies with a high risk of bias. Regarding heterogeneity, we had high levels of heterogeneity due to 2 outlier studies in which a technical issue was discovered in the background in the islet antibody measurement. So let's talk about numbers. The prevalence of antibody positivity ranged from 1 to 6% in our study, with lowest prevalence for islet cell antibody positivity and highest for insulin antibody positivity. The prevalence of any positivity was 4%, and of multiple lower, only 1%. So generally, low prevalence of islet antibody positivity was found in CF patients, which in numbers are closer to the numbers reported in the general population than in the type 1 diabetic. We wanted to assess whether glycemic status affects the prevalence of antibody positivity. Therefore, a subgroup analysis was made for diabetic CFRD patients and non-diabetic non-CFRD patients. We had high level of heterogeneity in those analyses where the previously mentioned 2 outlier studies were included, and more studies had a high risk of bias than moderate one. In the CFRD group, prevalence ranged from 1 to 7%, with highest prevalence for GOD and insulin antibody. The prevalence of any positivity was 4% in this 5% in this subgroup, and multiple only 1. Compared to this, in the non-CFRD patients, lower prevalences were found by 1–2% lower in all outcomes. So we found a tendency of higher antibody positivity rate in CFRD patients, but this difference was without statistical significance. So we wanted to assess the tendency from a different point of view. Therefore, odds ratios were calculated of islet antibody positivity between CFRD and non-CFRD patients. On this plot, you can see the number of patients tested and positive for non-CFRD and CFRD patients as well, and the odds ratios with 95% confidence intervals. We had low levels of heterogeneity and high risk of bias studies. The odds ranged from 2 to almost 5, and by being higher than 1 was consistently associated with CFRD. The strongest association was found for gut positivity with almost 5 times higher odds in the CFRD patients. Both any and multiple positivity had almost 3 times higher odds of positivity in CFRD patients. So altogether, we found higher odds of antibody positivity in CFRD patients with statistically significant results. This table summarizes the outcomes eligible only for a systematic review, and the overall assessment revealed that CF-related abnormal glucose tolerance presented earlier in islet antibody positive patients compared to islet antibody negative ones and with more complications. The strength of our study are that besides prevalence, odds ratios for islet antibody positivity were examined in different glycemic status patients, and we conducted a comprehensive analysis of several islet antibodies, including multiple positivity as well. Our limitations are that we had high risk of bias studies included and a statistical and clinical heterogeneity. So in conclusion, islet antibody positivity was detected in a minority of patients with cystic fibrosis, but in them it was linked to the development of CFRD and earlier onset of CF-related abnormal glucose tolerance with an increased risk of acute diabetic complications. So our implications for practice is that a routine screening is not needed in the CF population, but a closer monitoring of islet antibody positive patients is crucial. Our implications for research includes a risk stratification and studies focusing on further beta cell damage prevention in islet antibody positive patients. So to sum up where we are in the process with our first project, we have started writing the manuscript, and our targeted journal is the Journal of Cystic Fibrosis. So let's move on to our second project, where we are investigating the role of islet autoantibodies in a form of registry analysis. As I previously mentioned, the screening of islet autoantibodies in the CF population is limited, therefore data is missing about islet antibodies not just in the adult population, but in the pediatric CF patients as well. So with our second project, we are targeting this population and comparing CF children with islet antibody positivity to CF children without islet antibodies, and look for their glycemic status and the age of onset in case of an abnormal glucose tolerance. Our hypothesis is that CF-related abnormal glucose tolerance is more frequently present in those children who have islet antibodies and develops earlier. As data source, we are using the CF-related pancreatic disorder registry, started 5 years ago at Heimpálnessy Pediatric Institute, and nowadays around 100 children are followed in the registry. Our eligibility criteria include that we will include children under 18 years of age with a diagnosed cystic fibrosis, blood sample collected, and an available glycemic status. So to summarize our ongoing projects, we are investigating the role of islet autoantibodies in cystic fibrosis, first in a form of a systematic review and meta-analysis to see what's known in the literature, and the second project, the same concept in children in whom less is known to this day. And I would like to end my presentation with a quote from Gessler: "Children are not things to be molded, but are people to be unfolded." And thank you for your attention.
Congratulations to your presentation. It is very interesting. I would like to know if you would know anything about the prevalence of this islet antibody positivity in the general population, and, for example, in the type 1 diabetic population.
Yes, thank you for your question. So as I mentioned, we found higher prevalence in CF population compared to the general population, because in the general population, the prevalence of these antibodies ranges around 1 to 3%. And in the type 1 diabetic population, it's much higher, like 60 to 80% prevalence. Thanks.
Thanks for your nice presentation. It was comprehensive, but basically I don't have a lot of information about cystic fibrosis, but from the immunological aspect, I would like to ask about, I noticed that the prevalence of multiple positivity is low according to your results, and I think heterogeneity is not that high. So I'd like to ask you if you try to interpret this result, or if they are using ELISA to assess or to measure the positivity of the antibodies, or using other more accurate techniques?
Thank you for your question. Yes, we've also noticed that the prevalence of multiple positivity was lower in our study, and we hypothesized that it was mainly due to the fact that many studies reported multiple positivity as an additional result. So they didn't focus on actually measuring the multiple positivity, but rather as an additional finding. So the absence of multiple positivity was overrepresented. And mostly the studies included only 2 islet autoantibodies, so not all 5 or not more, and maybe it's harder to catch more antibodies when you are only including 2. And also what you mentioned that well, I think that approximately half of the studies used ELISA, which is a recommended tool for antibody measurement, but the guidelines state that radioimmunoassay performs better. So maybe these can be also the reason behind that. But I know that ELISA is cheaper than radioimmunoassay, so maybe that's why they use that.
Congratulations on your presentation. Regarding your registry analysis, what's your strategy for diagnosing CF-related diabetes in those patients?
Thank you for this question. In the registry, the children are diagnosed with a standard oral glucose tolerance test, and the guidelines recommend to start testing from the age of 10, but some CF experts suggest that an earlier screening should be implied. So in the registry, we are starting it from 6 years or...
Thank you very much.
Hi, my question would be that did you do a subgroup analysis, or do you plan to do a subgroup analysis by age?
Yes, thank you. Actually, we did a subgroup analysis by age, but due to the short time, I couldn't present these results. We included a subgroup for children, adults, and a mixed subgroup where we couldn't separate them from each other, and we found a tendency of higher antibody positivity rate in children, but this was without statistical significance.
Congrats for your nice presentation. My question is regarding to your first project, that there were 2 outliers,
yes,
causing the high heterogeneity. I was wondering what was in the background.
Thank you. As I mentioned, these outlier studies had a technical issue in islet antibody measurement, which is related to the thing for the ELISA, because these outlier studies used ELISA, and actually they used a unit of measurement that no other study used before. And yes, radioimmunoassay performs better, so maybe this is one of the reasons. And the other study didn't report on which method they used for antibody measurement.
Thank you.